Good afternoon, everybody. I'm going to speak about infiltrate in Lasik interface. आया नहीं. How many of you are doing Lasik regularly? Let us see what is Lasik interface. With the advent of keratomiliosis procedure, primarily Lasik, a new anatomic region in the cornea came into existence, the potential space between anterior and posterior corneal lamellae, commonly referred to as Lasik interface. A number of biochemical processes occur after creation of the corneal flap, including limited wound healing and intercellular reorganization. Anatomy of Lasik interface allows for a variety of potential unique complications to arise from different etiology with often overlapping clinical presentations. Primary interface complications include benign interface debris, infectious keratitis, diffuse lamellar keratitis or DLK, pressure-induced stromal keratopathy or PISK, central toxic keratopathy and epithelial ingrowth. Among the interface complications, infectious keratitis is usually most sight-threatening, while DLK is most common, and it can be confused with other conditions including infection, CTK and PISK. And epithelial ingrowth is generally easiest to identify and treat, although it may occasionally be associated with other disorders. Differentiating between interface entities rapidly is critical to appropriate diagnosis, treatment and management. And while initial similarities exist, but you have to take a careful history of symptoms, timing, onset, combined with focused clinical examination, and frequent follow-ups are necessary to arrive even at an accurate diagnosis depending on how the disease progresses. While each of these entities may belong in initial differential diagnosis of patients, and symptoms and interface finding mostly can be quickly diagnosed based on key historical elements like time of onset after surgery, level of discomfort or lack of it, as well as thorough physical examination, and IOP measurement is a must. And you must note that interface complications evolve in appearance over time, so frequent follow-ups are a necessity. This slide shows the difference in etiology. Typical onset, like in DLK, it is early onset 1 to 5 days, CTK it is 2 to 7 days, PISK 10 to 21 days, and infection 3 to 21 days. And initial effect on visual acuity is also different in different entities. And location is typical in DLK is diffuse, CTK is focal and well defined, and corneal haze is granular in DLK, while it is dense focally in CTK. So these are the important findings. Infection keratitis etiology can be a variety of organisms, including viruses and bacteria and fungus. When you see in adenoviral keratitis, it is usually has a relatively benign course with ultimately good visual acuity, while herpes simplex keratitis frequently leads to loss of best acuity after PRK and Lasik, and it is a relative contraindication for excimer laser surgery. This is a typical infiltrates after adenoviral keratitis in a post-Lasik eye. And non-viral keratitis could be atypical mycobacterium. Normally atypical mycobacterium is seen when it arrives little later. Methicillin resistant Staph aureus, Streptococcus species, Pseudomonas species, fungal infection and Acanthamoeba are less common organisms. Early onset is methicillin resistant, and late onsets are either atypical mycobacterium or fungal. This is a typical picture of infective keratitis. And the important feature in infective keratitis is, since there is an interface, infection tends to, all the exudates tend to trickle in the interface bed and progress very rapidly. This is another picture of infectious keratitis. And there can be sterile infiltrates which look infectious, like infectious keratitis, especially if it is not in the undersurface of the flap. So these respond very well to steroids, so it should not be mistaken. Risk factors for development of infectious keratitis include blepharitis, dry eye, intraoperative epithelial defects, intraoperative contamination, delayed postoperative reepithelialization of cornea, and use of topical corticosteroids and patients in health profession. And management is to lift the flap and take cultures, and the flap bed should be irrigated with fortified antibiotics, and broad spectrum topical antibiotics should be started. And for infections with a delayed onset, use of amikacin may be beneficial in treating atypical mycobacteria. In non-responsive Lasik infections, flap amputation may be necessary to facilitate antibiotic penetration. DLK is white blood cell infiltrate that coalesces between the flap and the stromal bed, that appears within first few days, 1 to 5 days after Lasik. And confocal microscopy has confirmed the presence of inflammatory cells in the central stroma and interface. This is what a typical DLK looks like. You can see multiple small whitish infiltrates in the cornea. The cause is supposed to be bacterial endotoxins, especially the sterilization reservoirs and intraoperative epithelial defects. It can be staged into 4. A stage 1 where inflammatory cells are in the periphery only, and stage 2 where is diffuse infiltrates, frequently involving paracentral and peripheral flap margins, but these are also sparing the central axis. And stage 3 has a denser infiltrate within the flap interface, which involves the visual axis and is frequently associated with decreased visual acuity. Stage 4 has a focal coalesced dense haze with scarring, signifying flap necrosis, and it usually results in permanent corneal scarring with visual acuity loss of varying severity. And DLK is highly sensitive to steroids and responsive to aggressive topical steroids for mild cases, and frequently you will need hourly administration, and sometimes in severe cases you may need to combine with oral. And many surgeons advocate use of oral steroid for stage 2 and 3 DLK, and flap lift can be done for stage 2 and stage 3 cases. For stage 4, flap lift is not advocated, and for stage 4, aggressive steroids to minimize scar density are warranted, and it may be partially effective. Reported uncorrected and corrected visual acuity after DLK resolves is generally quite good. However, this may be misleading, as DLK appears to affect visual acuity and contrast sensitivity more than absolute Snellen acuity measurements. DLK frequently induces a mild or moderate hyperopic shift after resolution, and with potentially both regular and irregular astigmatism, especially in stage 4 cases. If significant ametropia persists, patient may undergo retreatment without increased risk of developing DLK a second time, as long as inciting issue has been resolved. And sometimes you can prefer PRK to repeat Lasik. CTK is a rare and acute non-inflammatory central corneal opacification that can occur within days after uneventful Lasik or PRK. Etiology is unknown, but it may be related to enzymatic degradation of keratocytes. Confocal microscopy has demonstrated activated keratocytes without inflammatory cells with initial keratocyte loss. CTK has been reported to demonstrate anterior curvature flattening without alteration of posterior curvature in anterior segment tomography. Onset is acute without worsening over time, so that is why the follow-ups are important as opposed to most interface entities. This is what a typical CTK picture is like, and generally it resolves on its own. No steroids are required, and it is almost always painless as opposed to DLK, and surgical intervention will not help and will worsen the final outcome. Pressure-induced keratopathy is because of raise in the higher intraocular pressure. There is a result of fluid accumulation in the interface, and fluid may be relatively small, resulting in diffuse haziness of the interface. And this is a more complex entity to identify. This is what PISK looks like. This is a more clear picture of PISK. You have diffuse haze in the interface, and this is a severe form of PSK where you can see interface fluid layer. And sometimes IOP measurement can be faulty because you measure the pressure in the pressure of the interface fluid. So careful measurement of IOP is important, especially dynamic contour tonometry may be employed. Epithelial downgrowth is easy to identify, and it is treated with the flap lift by removing the epithelial cells. And lastly, you can also use YAG laser to treat epithelial downgrowth. When it comes to distinguishing infectious keratitis from other possible etiology, appearance of a focal infiltrate at any time point or a new infiltrate of any configuration more than 1 week after Lasik should be presumed infectious unless proven otherwise. And in that case, it is better to do scraping and culture. And generally, it is associated with foreign body sensation, vision reduction, conjunctival erythema, and pain. And DLK should be distinguished by early onset and evolution over period of time. Unless treated, it progresses. And DLK can takes PISK roughly takes 2 weeks to develop, so it is easy to identify. These are the chart for signs and symptoms of interface disorders. And management is, as we have already discussed. So to sum up, a variety of complications can present in Lasik interface with overlapping clinical features, but unique mechanism, time course, and management strategies. Differentiating between these interface disorders by taking a careful history of symptoms and onset, combined with focused clinical exam, allows for accurate diagnosis and treatment on presentation. Close attention to these specific features should lead to clinician to rapidly identifying the appropriate diagnosis and optimal management. Thank you.